Welcome, everyone. We're so excited to have you this evening. This is the Health Equity and Breast Imaging Facebook Live discussion brought to you by the Society of Breast Imaging. My name is Dr. Amy Patel, and I will be moderating this evening. I am so excited to present to you these expert panelists from around the country as we hope to engage in very robust discussion with you tonight about health equity. So let's get right to it. I'm going to introduce the panelists and then we will get into the questions. I ask that as you have questions, please put them in the chat box. And then at the end of the discussion, we will have time for Q&A with our participants and the panelists. So let's begin. First, I'd like to introduce Dr. Nina Watson. She's a breast radiologist based out of Atlanta. Thanks, Dr. Watson, for joining us. Dr. Peter Eby, who is a breast radiologist at Virginia Mason Medical Center. Thank you for joining this evening.
You're welcome.
Dr. Sidrina Calder, a primary care physician for the Tennessee Department of Health. Thanks for joining us. Dr. Regina Hampton, a breast surgeon at the Breast Care for Washington. Thank you for joining.
Thank you.
And Ms. Juliet Queensborough, a breast health navigator with Mattapan Community Health Center in Boston, Massachusetts. Thanks for joining us this evening.
Thanks for having me.
All right, so let's just hop right into it. Okay, so I have my first question for Dr. Nina Watson. What do we know about genetic mutations in Black women?
Now, if we were to sort of sum it up in one sentence, is that while there, is still a lot to understand and learn, studies are showing that genetic mutations play a much more prominent role than we may have initially thought. We have learned that African-American women are at higher risk for BRCA1, BRCA2 genetic mutations than those women of Western European ancestry. And as a result, then, these women are at higher risk for breast cancer. Now, if we are to look at women who have been diagnosed with breast cancer, the percentages vary, but somewhere around 22, 25% have a genetic mutation. And one of the pressing issues about this conversation is that Black women are less likely to undergo genetic testing. A major contributing factor is simply that genetic testing isn't being offered. So, despite the fact that, we're diagnosed with breast cancer at a younger age, higher stage, more likely to die of breast cancer, unfortunately, we're less likely to be offered genetic testing. And that really is something to, sit for a few moments and think about. An individual knowing that they carry a genetic mutation, it could have, a potential effect on decisions that they make regarding their treatment. Future screening, risk reduction surgeries, and not just for that individual, but also for their family members. For instance, if a woman knows that she has a BRCA mutation, breast MRI could be considered in addition to just her annual mammogram, not just for her, but also for her first degree relatives. So this is important information. Research being performed and aimed at increasing our understanding of these mutations is vital. Interventions focused on identifying patients who have a high risk of mutation, understanding the patients understanding the benefits of testing, and also trying to remove any financial or any administrative barriers could help improve outcomes. It can help patients and their families make the most informed decisions, which is our goal. It's improved patient care.
Yeah, I think genetic testing is a challenge, especially in minority communities. I know in my community here, just outside Washington, D.C., I do see a lot of younger African-American and actually Latina women as well. And I aggressively test and they end up being BRCA negative. And I have even some families, African-American families, numerous first-degree relatives. In fact, I have a family of 4 sisters. 4 out of 6 sisters have all been diagnosed with breast cancer under the age of 50. And we've tested them and they test negative. I know there is some work being done now where they're looking at BRCA testing in African-American women, and also going back to Africa, in fact, Ghana, and doing testing. And some of the early results show that there is a linkage there. But I think just in my personal experience, it seems to me that women of color are going to have a different genetic mutation, which is why it's so important that we try and get these women involved in clinical trials so we can get those answers.
That's true, but there are also a number of studies that are showing an increasing number of Black women with BRCA mutations when compared to women of Eastern, European Western ancestry. So I think that it does play a role, particularly in looking at young Black women who are, diagnosed early, diagnosed before the age of 40. We are seeing increasing numbers of genetic mutations in that population. And even in testing, doing the research, those results are going to be limited because Black women are less likely to be even offered genetic testing, which is important.
So kind of parlaying from what you've discussed, both of you, Dr. Hampton and Dr. Watson, as you know, Dr. Watson and Dr. Hampton, the breast imaging community in particular is shining a light. And so Dr. Eby, I'd like you to maybe discuss the new ACR screening recommendations in above average risk women, particularly regarding African-American women, if you could share any of that information with us.
Yeah, I'd be happy to. I think that Dr. Hampton and Dr. Watson have summed this up very, very well in what we are learning in the last decade, or even more recently in the last few years, is that there are more genetic mutations among Black women, and we need to be able to identify them. And they've already stated this, and I think the ACR absolutely supports this. The ACR is recommending that all Black women be evaluated by the time they're 30 for family history, essentially, to try to figure out which ones might be at risk, which ones might benefit from genetic testing. I mean, this is a huge ask, right? This is a very important and very large part of our national population who haven't had this kind of attention up till now. And what we know is that women with genetic mutations will have breast cancer at a young age, many times younger than 40, in fact, when we would recommend annual screening for everybody. So for this particular population, we really want them to be seen and evaluated by their primary care provider, like Dr. Calder, and have a full family history taken to see if they need a genetic test.
And I would like to add something to that. So as previously stated, so I work for the Tennessee State Department of Health. So I am in public health. Majority of my patients actually don't have insurance here in Tennessee. We have not expanded Medicaid here. So genetic testing is just not an option for many of my patients. A lot of them don't even have any income at all. I think it's important that we try to figure out ways that we can expand the access to genetic testing for this population. This is the most vulnerable population that we need to pay attention to. We have to figure out ways to address that.
I think it's also important, as genetics has expanded and multiple companies are starting to do testing, I think it's really important that these companies share their data. I know that's been a challenge in the past, but there was a paper out that showed that there were some variants of uncertain significance that were higher in minority populations, and that data has not been released. So I think, as a community and the medical community and the public community, I think we need to really push to get that data into a central repository, because those could be some potential lives that are in that data that we could save. So I think it's just so important that that we look at sharing data and sharing information to make the most impact.
And I think it's also so important that we get the word out there that, you know, all women should have a risk assessment beginning at age 30. And that's information that, you know, some know, but I think, you know, we all can do, you know, further work in spreading the word, because it's important to identify women who need to begin screening earlier than age 40.
I think that also brings a unique challenge as well, because I have quite a number of patients who they come in and say, well, no, I don't have a family history. But then when they're diagnosed, everyone in the family starts talking about, well, and aunt so-and-so and grandma. And, you know, my grandmother always had one breast, but no one ever said the word cancer. So there are just still some of these myths that really hold back information in families that can be invaluable. And even beyond breast, I mean, colon cancer, prostate cancer, you name a cancer, you know, minority populations usually get it early. So we really have to open the conversation and realize that just because we say the C word, it doesn't mean someone's at risk. But you know, we could save another member in our family by talking about our histories.
And given what you're saying, oh, I'm sorry. I was just going to say, given what you're saying, Dr. Hampton, Miss Queensborough, in your experience, what do you see when you are interacting with these patients and their families?
One of the main factors is lack of financial support. There's a language barrier. There's a communication issue. There is like issue with the healthcare system, transportation system issue, fears. They're misinformed. They have lack of family support and biases based on race, age, and so on.
Anyone else would like to add to that experience?
Just to chime in on what the previous presenter have said, for the genetic testing, I've seen quite a few patients comes in. They do have insurance, but the insurance doesn't want to cover that genetic testing for that. And on the other hand, some doesn't have access to any form of insurance either.
But you also have some of those myths in those communities, and you get those who say, well, we just don't want to know. And it's like, well, no, we really want to try and make a difference. And, you know, what I explain to patients is just because you get the test and you turn out positive, you have options on the table. You know, it doesn't mean that you have to go immediately to surgery, but you have options. We can put you on medication. You know, we can do increased screening. So I think, again, just sort of that getting that word out and taking away that fear and that stigma in many of these communities is key.
And with that, Dr. Hampton, you know, Dr. Watson, I mean, how crucial do you think fostering community partnerships are in achieving health equity and getting that word out like we're discussing tonight?
You know, my answer would be like a wholehearted yes. Community partnerships, relationships, they're essential. They're the only way we're really going to be able to address health disparities. You know, if you look at the complex issues that need to be addressed, you know, yeah, there may be some biological differences, but then, you know, we're also dealing with social differences and economic issues, access to care, availability of resources, you know, access to support, and community organizations can help to fill some of those gaps if they exist. And also they can help to provide educational support services, you know, breast cancer educational material, access to screening services, information and support for patients, their families, breast cancer survivors. So I think working together as a team definitely has positive benefits.
Agree. Co-sign.
Yeah. And, you know, working in public health, we utilize community partnerships a lot. That's the best way to engage the local population. Those organizations know those populations better than anyone else. So it really helps us to figure out ways and devise ways to reach those people. So yeah, partnerships are definitely important.
Because those partnerships, you know, it helps to increase impact because you can share resources. You can also like share strengths. If, each partner can lead a project based on, what is their area of expertise, such as me, I'm a breast imager. So my area of expertise may be in discussing the benefits of screening mammograms. A community organization may be really good at hosting events. When we come together, it gives me the opportunity to share my knowledge with the public and also reach individuals who I might not have otherwise.
Yes, I think that's so crucial. Oh, I'm sorry. I was just quickly going to add that particularly in Kansas City where I practice, one thing that I have taken upon myself, just because we're talking about partnerships, is I've actually been speaking on Sunday services at some of the local churches in town. I have found particularly, what's really sad is I practice in Clay County in the state of Missouri, which has one of the top 3 breast cancer death rates county-wise in the state of Missouri for African-American women and Hispanic women. So for me, I've made it my mission that we need to reach these groups. So I found that, speaking at churches and Sunday church service has been a great way to connect with the community.
And yeah, absolutely. I think it's also important. The community needs to know that you're going to be there. I co-founded a nonprofit in Ward 8 that's similar to your community, Dr. Patel, that has one of the highest mortality rates in DC. And when we first opened, we thought, well, we're here, we've got 3D mammography, people are going to come. And what we found is that people were like, okay, we see you all, but you're probably not going to be here in about 6 months. You're just going to sort of fly by night. And it's like, well, no, we've got a big mammogram machine. We're not going anywhere. And as they saw that we were in the community, we got navigators who are from the community and live in the community. And that's really been a big help in doing outreach and then feeling like, we're a safe place. We're here for you and we're going to guide you through. In the way that's appropriate for you. If you're, Spanish speaking, we're going to get a Latina navigator to help you out. So really trying to meet the community where they are is key.
So I think a lot of it is about trust. And I think as we know from the data and from the experiences that people have reported that minorities have not always had respectful experiences with the healthcare system in the United States. And it's really our job to rebuild that trust. I think it keeps them from coming and we can certainly do better. I'd love to hear your strategies, everybody's strategies for how to reach the community. I know, Amy, you've already talked about speaking at your local church. I'd love to hear other strategies that you all have.
Yeah, I've done the same thing, going and speaking out at church groups, women's groups. Almost anytime anyone asks me to come out and do an event, I try to get out there, especially being an African-American surgeon in this area. They don't often see someone who looks like them, who, really can understand. And I think I can kind of connect with them on a certain level. And sometimes I can say things that maybe other providers can't say, but we get that connection. And so I think just trying to be out there and be available to the community and sometimes meeting them where they are. I often have patients, even once they are diagnosed, just trying to get them in for their treatment. There can be some delays, again, because of that fear. I had a young lady recently who she was diagnosed in June, and she said, well, I've got some family things going on. I'm not going to be able to get to surgery to the end of July. And so it took our team really just working with her through that, trying to get her the support so that we could try to get her in for her treatment a lot sooner. And she may go to another institution and they may just say, well, she's being difficult and, she's not committed to treatment. So, sometimes it means kind of, meeting the patients where they are. And sometimes we have to agree to disagree. But, I let my patients know, I'm not going to close the door. And if you say that you've got some challenges, let me see how I can help you. If not, then, I'm still here when you can get here.
That is so true. Good. Sorry. Yeah, that is so true. Because, I've seen in many instances where just like persistent telephone calls. You know, you might call the patient, you know, they don't pick up, but you call a few times and then, you know, you continue to leave those messages. And then one day they'll pick up and they're like, okay, this is enough messages. I will come in, you know, I will come in, you know. And the church services, as you said, you know, it works well. We have community outreach where we have events, you know, where we would invite the patients, you know, to come on in. We have speakers to address their different needs. We'll go to the barbershop, the hair salon, anywhere, you know, we can find the opportunity to just spread the word about the importance of having your screening mammogram done, you know, provide informational pamphlet and just about anything, you know, just to get the word out.
I love those ideas.
I know they're great ideas. I do some work with media outlets. So, you know, magazines, also, you know, being interviewed by nonprofit organizations, a lot with social media. So, you know, some Facebook Lives, IG Lives, you know, all in an attempt to reach, you know, different patients and, you know, public who I normally wouldn't be able to reach.
You know, I think, you know, one thing that I think is interesting when you look at, you know, the white community, just sort of their approach in many cases to breast cancer is just totally different. You know, if there's a diagnosis, they're coming in, they're getting treated, they're moving along. And I think that's because there are more examples and public examples, you know, where they come out and say, yes, I have breast cancer, I got treated. And in our community, there aren't that many people that our women can point to. I mean, I use Angelina Jolie and Wanda Sykes, but it'd be nice to have just a list of names of women and men, you know, who've gone through cancer, because then I think the people could identify with that, and that might be helpful. You know, we talk about the BRCA mutation, and, you know, Beyonce's father, Matthew Knowles, is a BRCA mutation carrier. And, you know, I don't know if you all have thought, but just sort of as a clinician, I'm like, well, is Beyonce and her sister, might they be mutation carriers? And if they are, wouldn't that be powerful if they came out and shared their story? I mean, I think that's where we'd see a turn, because, you know, Beyonce's power is just it. And I think a lot of women would identify with that. And really, that could really make a big difference in the minority community. So I don't know if she's listening, but we want to know. And her father's doing well, by the way.
Even if she's not, she can be an advocate, right?
Yeah.
Her father, her family, she's got a story to tell. We'd love to hear it.
So along those lines, Ms. Queensborough, do you have any specific, just in your expertise role as being a navigator, do you have any specific resources that you perhaps steer patients towards and families, or to providers that may help regarding health equity?
Sure. So first, we have a financial service counselor right on site. The patient comes in and we realize that there's no insurance. We set them up with a financial counselor who will help them to get insurance, and so that they can come in for their mammogram. We might call a patient and they says, okay, I do not have access to transportation. We have a ride-share system that we offer to them. It will pick them up, take them to their appointment, and take them back. So that helps a whole lot. That helps a whole lot too. And also, we have, if it's in a case where they're going through a lot, like trauma and all of that, we have a behavioral health facility right on site that we can introduce them, you know, to someone, get them to have the proper care they need so that, you know, they can feel comfortable and, you know, continue on with their life.
Wonderful. Dr. Calder, do you have any resources that maybe you all share with patients, providers in Tennessee?
Well, for our mammogram screening, breast cancer screening, we actually have a program for that, which has funding to provide mammograms for anyone that meets the USPSTF guidelines. Unfortunately, we've been discussing, African American women actually need to be screened earlier than that. So, but that's what we're doing. So we are doing something. In terms of other resources, we provide, a lot of education, whether it's in the form of me speaking to the patient themselves, or we have a lot of pamphlets and print material that we provide as well. In addition, they also do different events from time to time within the local communities as well surrounding breast cancer awareness.
Yeah, I think you bring up the USPS. I always get the letters confused. The USPSTF task force guidelines, and it's amazing that there still are providers and organizations that are still following those, despite I know SBI came out, ACR came out. I know our Society of Breast Surgeons joined in with that. So I think we've just got to speak louder so that people know that that's available, especially our primary care providers.
There's actually an attendee on the webinar right now who made a comment in the chat box about how, unfortunately, USPSTF recommendations are still being taught to medical students. So it's unfortunate how it begins so early. And, what can we do as a community to really continue to drive the word out regarding the recommendations that our expert community has for our patients and providers?
Yeah, there's no question that the guidelines that the task force has issued result in loss of life. We know that annual screening starting at 40 saves the most lives. We acknowledge, of course, that there are some recalls, there are some biopsies that are done on patients that turn out to not have breast cancer, but there's no perfect test. The models that have been used to inform the recommendations all show that annual screening starting at 40 are going to save the most lives. That's why the SBI and the ACR, along with American Society of Breast Surgeons and the gynecologists, recommend that approach. Now, women are free to make their choice about when and how they want to come in and get care, but starting at 40 is going to save those. And that's for average risk patients. We've talked a little bit on this call already about how there's definitely an increased risk among Black women, and they absolutely should be given the recommendation and the option to start at 40. We know that not only are Black women 42% more likely to die from their breast cancer, but they also get them earlier. So I think we just can't stress enough how important it is to start at 40.
And I think it's important for women to be empowered to be their own advocate. And, if you're seeing a provider who is discounting you because of your age, even if you have a lump, keep knocking on doors until someone takes you seriously and takes a look at that to see what's going on. And in most cases, it may be just a cyst, it may be a fibroadenoma, it may be a number of benign things, but you don't want to just be discounted just because of your age. You want to be taken seriously. And, I tell people, just keep knocking on doors until someone hears you, listens to you, examines you, and takes action to answer the question.
This is a question I have for all of you, and it kind of ties into what we've been discussing in this kind of recent segment. But what, in your experience, what concrete steps have worked to improve outcomes for Black women? And is there anything else do you think we should try collectively as a community that maybe we just aren't really hitting the nail on the head at this point in time?
I mean, one thing for me has been, is just on the small scale, on the patients I see, is education. It's like once you have the knowledge, then you're able to make informed decisions regarding your care. So whether that's, information about the benefits of having an annual screening mammogram, it's, talking about if, biopsy is recommended, providing the necessary information, and then sometimes also taking time to address concerns. Sometimes a biopsy may be refused just because, they may not have a full understanding of the procedure. So taking that time to have those discussions, and sometimes it's only, a few minutes, can make a change in how they, decide to handle their treatment.
And I think just kind of staying on top of my patients. So even after education, there are some patients that will still refuse. I had a patient that said, I don't want it done. I'm afraid of getting a mammogram. So I'll say, okay, that's fine. And the next time I see her, then we'll talk about it again. So I just try to stay consistent with the same message and, try to hopefully be able to convince them eventually to get it done.
Yeah, I do a lot of educating because there are, a lot of rumors and word on the street in a lot of these communities. Still people say, girl, don't get that mammogram because it's going to cause cancer, or, all they're going to do is flatten you like a pancake. And so, I actually explain why compression is necessary. And so people are often surprised, and I put that in a lot of my talks. They're like, oh, well, if someone had explained that, then okay, yes, please squeeze on, do what you need to do so you can see what's going on. So I think, just trying to make things relatable so that people understand the why, why we're doing things. I think it's also important for people to know on the treatment side, the treatments have changed vastly, just even in the last 5 to 10 years. So triple negative tumors, which we see often in our younger African-American patients, we've changed how we treat those. So we give them their most important treatment, which is chemotherapy. We give it up front. And those tumors are some of the best responders to chemotherapy. So, I've had, 7, 8 centimeter tumors completely go away before I've even taken them to surgery, which then puts a lot more surgical options back on the table. She would have had to have a mastectomy. Well, now she could get a lumpectomy if she wants to. So, these are the wins that I think, for us in the medical community, we need to, celebrate and let women know. And then I think we also need to empower those survivors to tell their stories. And to realize not everybody may be ready to hear your story, but your story is going to touch someone. It's going to encourage somebody to go get a mammogram or to do their own breast exam and to take action.
Yes, just to chime in on what Dr. Watson just said. As you said about the survivors to tell their story, every October, we usually host what we call a breast health night. We will have at least 3 survivors come and share their story. We had even a male in the audience at one time, and the turnout was great. They shared their story. Everybody was moved. And on that day, people were signing up to come and have their mammogram done. So that works, a great deal. We'll also have a presenter to come and share the facts, surrounding mammograms and how important it is to have one done. And another step that we used to, working in an health center facility, I would try to intercept the provider's schedule on a daily basis. And we would target those patients who were at the age of 40 and above who are eligible for mammogram. And we will flag the provider to let them know that, okay, this patient is due for a mammogram. Can you have a conversation with them during the visit? The provider will send down that patient. And the good thing about it, we offer mammogram right there, and we also take walk-ins. So that helps a whole lot.
Yeah, because usually, once that patient is there, you want to take advantage because they may not come back.
That's right.
That's one of the things that we're looking at. We recently got a screening mammography unit, And it's great, we do the screenings. However, what we've found is that where our fixed location is, it's a barrier. And so I want to look at how we might be able to do diagnostics on the mobile mammography, because they're there. Most of them need a diagnostic. And so how can we do that? So we're really looking into how we can be creative to provide that service.
I think we've heard from a couple of different people that fear, unfortunately, plays a role in the access issue that we have, right? Whether it's fear based on a family member who had a bad outcome, or simply the fear of breast cancer, the pain of a mammogram. I think certainly these are things that we can all address, but it is a challenge. You know, Dr. Calder, one of the things that I do when I get to meet patients in the breast center is I tell them, yeah, 1 in 8 women will get breast cancer, but 7 out of 8 won't. And I think women often tend to fixate on that 1 out of 8. I try to shift it back to the 7 of 8 and try to remind them that getting a mammogram is that proactive step just to show you that you're fine, right? 7 out of 8 women are going to be fine. 7 out of 8 women are never going to get breast cancer. This is your annual opportunity to do something for yourself and just show yourself that everything's okay. That's one of the ways I try to break down that fear of the mammogram. But, you know, Ms. Queensborough and Dr. Hampton, you've also touched on the idea of positive stories. And I think, you know, what we see in the data with younger women with more aggressive tumors, in the Black population is there aren't as many positive stories. And unfortunately, I think it's a cycle, right? So with negative outcomes comes more fear, comes more reluctance to go in. And that's a cycle that we need to break. You know, and I think we also have to be honest in that, you know, providers in this country haven't always offered the same amount or levels of care to Black women as they have to non-Black women. And that impacts those stories, right? That has had an impact on how many have positive outcomes and how many haven't. And we can do better. There should be equity across the treatment that's offered. There should be equity across the explanations that are offered. There needs to be equity and dignity for all women so that they can all have positive outcomes whenever possible.
So we've been talking a lot about particularly, you know, insurance and in lack thereof, unfortunately, in a lot of circumstances. Dr. Eby, how has the expansion of Medicaid made a difference for any of the victories that we have had?
Yeah, you know, Medicaid expansion has been very important for this country to get people even basic insurance so that they can have preventive care. And there have been some folks who've really tried to look deeply into how Medicaid expansion has affected minorities across all different kinds of diseases, but breast cancer in particular. What we see is that in states that have enjoyed Medicaid expansion under the Affordable Care Act, the time from when they get diagnosed with breast cancer to the time treatment starts has decreased. So they're getting to their treatment faster, right? So there's more resources, there's more insurance for those women. So that's really important, right, to get to treatment after diagnosis. What we've also seen is that mortality rates, the death rate from breast cancer for some minority populations has improved with Medicaid expansion. Again, like just people having basic access to care. We've talked a lot about it. If you can't afford a mammogram, you're not going to get a mammogram. And Medicaid expansion pays for mammograms. You know, it goes a long way to helping women. But what we haven't seen, which is still, there's some mixed results though for Black women, is that Medicaid expansion hasn't necessarily resulted in better mortality rates. So we still have a lot of work to do there. Even though treatment is being started earlier and more women, I think, are getting mammograms through Medicaid expansion, we still have a lot of work to improve the mortality rates for Black women.
I think it's also important that these programs, you know, it's great that we have the breast and cervical cancer programs that cover, you know, the breast exam and the GYN exams, but if we need to get that patient into treatment, sometimes that can be a challenge. Like if I need to take the patient to surgery, we've got to find a way to cover the primary care visit so that they can get their pre-op workup in order to have the surgery. So, I think we've got to get these programs to really think of the whole woman, because kind of everything affects the next thing when we're looking at these programs. And I think more people need to know that the programs are out there. The breast and cervical programs are out there and in all states.
And I just want to echo that, particularly in Missouri, we have the Show Me Healthy Women program where women can qualify for BCCT Medicaid, similar to what you're describing. And just the becoming a Show Me Healthy Women provider is just so difficult to do as a breast center. I mean, we're currently in the throes of that. And it's just all the bureaucratic red tape, all the steps you have to go through to even help one patient. And I can see how if you're in an incredibly busy practice or institution, that in and of itself could be a barrier, which then can affect these patients. So I think, even these programs running more efficiently, reducing that, making it more accessible to us to be able to help these patients is crucial. I mean, the programs exist, the money is there for these patients. It's just being able to access them effectively for these patients. All right, so I have one more question before we get into the Q&A. This is first for Dr. Watson, but then anyone else can chime in. So you're known as a wellness champion and expert in many ways, particularly in our breast imaging community. What do you recommend that patients can do to lower their breast cancer risk?
So I think that, these discussions about lowering your risk, they're vital because there's so much that we can't change. We can't change our genetics, we can't change our family history, even our own past medical history. We kind of have to work with and accept. But there are changes to our lifestyle, to the things that we do every day that can lower our breast cancer risk. And these things do deserve consideration, not to be inclusive, but one is, increased physical activity, a greater reduction in the risk of breast cancers associated with, increasing amounts of exercise, and then also more vigorous exercise. Nutrition, what we eat every day may affect our risk. Alcohol consumption, tobacco. And then, one of the key points when looking at the modifications in these areas is that, yes, not only may they lower our risk of breast cancer, but they also lower our risk of other types of cancer, lower risk of diabetes, also lower risk of heart disease. It promotes overall health and wellness, and there are changes that we can make.
Would anyone else like to add to that question?
Well, I completely agree with Dr. Watson. I think, but there's a challenge right now with COVID, right? It's hard for us to exercise. It's hard for us to exercise together. I think that's a big barrier, right? It's hard for us to get out and eat right with COVID. I don't know if anybody has any suggestions.
And that's why I say increased physical activity, that could mean different things for different people. Yes, for some people that could actually be, exercising. It could also be, instead of taking, the elevator, taking the stairs. Things that you can do within your apartment in small spaces, tons of YouTube videos to help with that. And when making these changes, oftentimes we think if we had to make some, major change, I need to exercise 1 hour a day, 7 days a week. The focus should actually be making on small changes. It could just be walking 10 minutes a day, walking 20 minutes a day, but you want to make changes that can be maintained and can be incorporated into a lifestyle.
Okay. Well, Dr. Evie, I'm glad you brought up COVID because that leads us to our first question in the Q&A. So one question we received from those who are listening in tonight is, how do you think COVID-19 will affect screening utilization by women of color, especially given the economic impact on their families?
Well, COVID has been a problem for all of us. we basically shut down our screening program entirely in March and didn't let anybody come in unless they had an acute symptom for diagnostics. So, we took a couple of months off for screening, and we're just hoping that women are going to come back. I think it also comes back to a lot of the things that Ms. Quinsborough has mentioned, that Dr. Calder has mentioned, Dr. Hampton has mentioned, is that there are barriers to women for getting their screening mammogram, on top of the transportation, on top of insurance, on top of time. Women, you add COVID, and it's, for some, I think it might be the last straw sometimes. I don't know what the experience has been with the rest of the members of this panel, but it certainly has, I think, just been another barrier to care.
And I can speak to that. Working in public health and with the population I serve as a safety net facility, a lot of my patients have lost jobs during COVID. Or never had a job, and this just kind of makes things a lot worse. So breast cancer screening is not at the top of their list right now of things to do. Pretty much, sometimes it's hard for me to even get them back in just to make sure they get medication refills, because it's just not a priority. They have a lot of other things that are going on right now, especially with COVID, that they are not really concerned. Their health is like on the bottom of the list. So I think it's important to try to find ways to reach those individuals and address some of those other issues if we can, so that they can make their health more of a priority.
One of the things that we were doing, we actually shut down our facility in March as well. But what we did, we still connect with our patients. So we will check on them from time to time, just to ensure that they're okay, just like, one of those calls. And surprisingly, we've been calling them to let them know that, okay, we're back in operation, and we've had, like, they're coming in droves. Like, we have to alter the schedule just to fit them. So actually, I'm impressed. So maybe because, we stay in touch with them to let them know that, we're here, it's affecting everyone, and, we all are going through this. They're actually coming in now.
Great. Well, I actually have a question myself for all of you. So we talk about, we're talking about Medicaid expansion, and we're talking about getting the word out. I think about, and this made me start thinking about, our elected officials at the federal level, and how we are, particularly in this past legislative session, with particularly the House of Representatives, and that we had just had much more diverse representation than arguably than which we've ever had. How imperative do you think it is for us to reach out to our elected officials at a federal level to invoke change? And do you think that that could be an effective approach to, achieving the goals that we have for achieving health equity? And this is a question for any of you.
Yeah, I think, because we have so much more diversity than we've had before, I think it's an opportune time. I think, unfortunately, there are just so many other unimportant conversations going on in Congress that they can't get to really the business of making sure that citizens are taken care of and evaluating the meaningful legislation that's just kind of sitting on desks. So, I think it definitely is important. And for me, being in Washington, D.C., I always find it important. But I think we've got to get to a point where our elected officials are back to doing business and not nonsense.
It's interesting. We've had some success before, right? So I have hope. If you remember when the USPSTF first issued their recommendations, they basically are tied to payment for screening mammograms. They gave them a grade C for women under 50 so that Medicaid wouldn't have to pay for those. And elected officials came together and drafted and passed the PALS Act, the Preserve Access to Life-Saving Screening Act, which basically held off the loss of funding related to the task force for 2 years. And then it was renewed, I think, for another 2 years. So we've had some success. So certainly we can influence the legislation and the funding for some important medical care.
And there's a couple of breast cancer survivors that are in Congress. So I know they're big advocates to this legislation. And, you know, have always been willing to step up. And so I think once we can, you know, get to the point where our elected officials are back to doing the work they're supposed to do, I think a lot of this stuff could get passed. Now, I have a question. Is the task force still not recommending 3D mammography? Has that changed at all? Does anyone know? I know in the original guidelines it didn't.
Yeah, I don't think that's within the guidelines, 3D.
Okay, which is, you know, that needs to be changed. I mean, you know, it's clear 3D mammography is far superior and we're getting the best images that we've ever gotten. And so the fact that that's a barrier, especially for women who may be under Medicaid or be under, you know, some of the breast and cervical programs is a problem, because these are the women who are younger with dense breast tissue where we need that extra imaging in order to make, you know, accurate assessments.
I think that's an important point. We definitely see that tomosynthesis allows us to detect smaller cancers in dense breast, and also it reduces recalls. Remember that one of the reasons why the task force objected to women under 50 getting regular screening is because there were too many recalls, and tomosynthesis addresses that. But, you know, with the challenge, part of the challenge is getting all the units across the country switched over, and we still haven't hit 50% of all the units. Now, many facilities have at least one, which they can use to image women with dense breasts if they have to triage. But many facilities still don't have tomo. And so I would just say that a 2D mammogram is still a very effective tool. If that's the option that it's available to a woman who chooses to have a mammogram, please do it. Don't put off getting it just because 3D is not immediately available. A 2D mammogram is still a very effective tool, and it's what all the randomized controlled trials are based on that showed the improvement in mortality.
I also think too, it's a great opportunity for, particularly, you know, now with COVID and increasing financial difficulties, for these vendors who sell these mammography units, you know, come up with different plans, particularly for rural areas and rural pricing options, and make it more accessible. Because if we all truly are in this together to advance the cause of breast health and to you know, increase access for the most groundbreaking technologies for all patients across the board, then I think that those, you know, our partnerships, particularly with, you know, vendors who are making these units, I think it's important for us to talk about that. You know, the cost is such a huge issue, and you know, I feel passionately about that in particular is because I serve a lot of, you know, I oversee breast imaging for a lot of rural facilities, and just the challenges we've had to get, you know, 3D. Now I only have 2 facilities left that don't have 3D. So it's been a lot of victories, but still, you know, it's a dogfight. So, you know, if everyone, you know, wants to talk the talk, I hope that they walk the walk, regardless of whether you're a physician or you're a navigator, patient advocate, or you're, you know, creating this groundbreaking imaging for our patients to save lives. Well, we're almost about at the top of the hour. I don't see any other questions, but I did want to conclude the hour just to kind of leave the floor to you. For each one of you, I wanted you to share maybe if you could implore one takeaway for those who are listening in tonight. What would that be regarding health equity? And we can start with Ms. Queensborough.
Well, It has been a really interesting discussion. So I would, implore anyone who is listening to get your mammogram screening done. It is important. I always use myself as a way to tell patient when they come in, when they're having difficulties. I says, you know what? I'm practicing what I'm preaching. I get my mammogram done, and that kind of helps to alleviate some of those fears, some of those little doubts that they're having, and just sit down, have a talk with them, So it's very important to get your mammogram done. I've seen it time and time again. Screening is very important.
Great. All right, Dr. Hampton.
I think it's important for women to not let the statistics deter you. In fact, let the statistics empower you to get your own mammogram, to take a friend, take a loved one to get a mammogram, and realize that getting yearly mammograms is what makes a difference. Be your own advocate. If something doesn't feel right, if you think something is going on and you have providers that aren't taking you seriously, keep knocking on doors until someone really takes you seriously. And, just for everyone to know that, the treatments are not as aggressive as they were, and there are so many options available. But if you don't come in with that smaller cancer, then you have less and less options. And we want you to come in with more options because we want all women to win and be survivors.
Great message. Dr. Calder?
I would just address the healthcare professionals just as a whole. I think that we need to address some of our provider biases so that we can help our patients to feel more comfortable with us and trust us more so that they will access care more often. And if we increase the access, then obviously that will improve their outcomes as overall. So I think, addressing the provider biases, just looking within ourselves. I think everyone has their own biases that they may not realize, but just trying to address those and allow patients to feel more comfortable and increase and better their access to care.
Great. Dr. Watson?
Yeah, I think it would be, some things in our life we can't change, focusing on those things that we can do to modify our risk factors. And then also for physicians, we need to be, regardless of our specialty, be able to be comfortable and aware of the risk factors, having those discussions with patients, taking the time, taking the initiative to have those conversations.
And Dr. Evie?
Well, I think I would conclude by saying that breast cancer care is a team sport. And we have been lucky enough to hear from members of this team, right? We've heard from navigators, surgeons, primary care, radiology, and we all believe in the same thing, and that is getting equitable access and equitable outcomes for women across this country. The SBI supports that, the American College of Radiology supports that, and we clearly have a long way to go. Dr. Calder's right, there are biases that we all have. If you have a brain, you have a bias, and we need to address those, and we need to address the history and basically turn positive stories into more positive stories for Black women in this country.
That's a great message and a great way to leave off. So I just want to express my gratitude to our expert panelists tonight for joining us. And thank you to all for tuning in. Again, this was the Health Equity and Breast Imaging discussion, Facebook Live, brought to you by the Society of Breast Imaging. Thank you. Have a great evening and happy Breast Cancer Awareness Month.
Thank you.
Thank you.
Thank you.